whereas before we would see every 8 to 10 minutes a patient. And so that really cuts the clinical volume by 50%. And so that therefore our surgical volume has decreased as well. But we were shut down completely for about 3 weeks, only doing trauma. And then after 3 weeks, so around end of April-ish or so, then we started to do full surgery again.
Good.
And you? How about in Sao Paulo?
Yeah, now we are working. They start to working, and here it's the same in California. The people is going outside. That bars and restaurants just open, but we are also concerned that maybe we are going to have another wave of the virus, and even our president is now with coronavirus. Yeah.
No, really?
Bolsonaro, yeah. He is like Trump, huh? So Trump-like.
Yeah.
Jeffrey,
how sick is he?
Jeffrey, just to let you know, you have the lecture.
Yes.
How long you intend to take this lecture?
I think you said around 20 minutes. I can do 20 minutes.
Okay.
20 to 30 minutes.
Maybe 20 to 30 minutes is fine. And
okay.
Then we are going to have 3 cases. One chronic is scapholunate. Other one is acute one. And the third one is a middle carpal instability. Yeah.
Okay.
And to be more straight in the discussion, we prepare some questions after we present the case, specific questions, and then we can get some questions that the people that are attending the meeting in the chat. Okay.
Okay.
Ramis is going to pick the questions, and so be very straight about the discussion. We want to know how you do. You know.
Sure.
Okay. Just to give a source to discussion. Okay.
Sure.
Okay.
No problem.
Okay.
I look forward to it.
Yes, yes.
Everybody's here.
How's the weather? Too hot there? Jeffrey? Hot?
I'm sorry?
Summertime in California?
Yes, it's beautiful. It's beautiful.
Yeah. A brother that lives in Troy, near Chicago, and he said that awfully hot, 38 degrees, and that's all.
Yeah. There's a reason why California has the highest population in the United States, because it's such a popular place to live because the weather is almost always good.
Yeah.
In our area, the worst time is in between November and March, when it's just a little bit rainy.
Yeah.
But not very cold.
Yeah.
No snow, and the heat rarely goes above 90 degrees Fahrenheit, which I think is less than 30 degrees.
Yeah, that's it. Let's begin.
No, wait a little bit.
Wait a few more minutes.
Yeah. Jeffrey, you want to share the screen just to check if everything's fine?
Sure, hang on.
Dang it.
Ô Marcelo, tudo bom?
Bom.
It's okay?
Hello, Jeffrey.
Oh, hey, how are you?
Fine. How are you?
I'm well. Staying healthy?
Yeah, I'm healthy. Thank you. How's California regarding COVID?
It's okay. It's so far, some areas, Los Angeles area is very, very affected, unfortunately, and the cases keep going higher and higher, unfortunately, in Los Angeles. But in the San Francisco area, luckily, things are still okay.
Uh-huh.
But we do fear that there will be some spike in the future as people become, we call it COVID fatigue. They get more tired of this whole thing and staying away from people and staying at home. And so they get tired and then they start to go out and do more things and not wear a mask. And so we worry that there will be some more cases soon.
Yeah, yeah. Are you doing surgery normally or not?
We're about 70%. About 70%.
Okay, okay.
And you, I heard you're back to 100%?
No. We're in a very slow motion.
Very slow motion.
We're in reopening. We're opening now. So stores and restaurant, they're in partial time working.
Got it.
Jeffrey.
Yes.
Could you stop sharing, because I want to introduce you. So
Sure.
I'm going to present my.
So you can see this, Marcelo, okay?
Yeah, that's fine.
Yeah, we can see.
Yeah. So let's see. Just 2 more minutes, just to, people is coming. And how is the webinars in the United States? Here we are getting crazy here.
So many. Too many.
Yeah, too many.
This is already my 3rd one today.
Wow.
Oh yeah.
Yeah.
Sorry about that.
No. It's my pleasure. It's
I got first.
Yeah. It's my pleasure. It's and it's great. I think this will really change how we do meetings in the future. Of course, I do miss the in-person, seeing you all and interacting person to person, of course. But obviously, this is a lot easier to do than flying across the world to meet at some meeting. So So less travels in the future, huh? Right.
To stay home and do lectures at home.
Right.
Let me put it first. Well, let's see time. Let's see. Well, 7:02. Okay. So let's start. Okay, Jeffrey. I'm going to introduce you. Yeah. Okay. So good afternoon, Jeffrey. Directly from San Francisco. No, not San Francisco, Lake Tahoe. Yeah. Good night to the Brazilians who are watching us. Today, we prepared a webinar with Dr. Jeffrey Yao. He's a teacher director of Hand and Upper Extremity Surgery Fellowship, Robert Chase Hand and Upper Limb Center, Department of Orthopedic Surgery, Stanford University Medical Center in California. We divided this webinar in 2 parts. The first presentation, Dr. Jeffrey, about the arthroscopic approach of scapholunate injury. At the second one, we are going to present 3 cases. I had the opportunity to contact Dr. Jeffrey twice in Brazil. The first in an event of Brazilian Society, the regional Brazilian Society in São Paulo, about 5 years ago. And the second one, 2 years ago, when he made our Brazilian Congress in Fortaleza shine. His great experience in wrist arthroscopy placed him in great prominence as one of the world reference in this subject. A special thanks for accepting our invitation, even though you are on vacation with your family. I asked the people that is watching, seeing this webinar, that is send your questions in the chat. So we are going to choose the questions to send to Dr. Jeffrey when we start the discussion. So Jeffrey, please, could you? I'm going to stop sharing, and please share your presentation with us. Thank you.
Thank you. Obrigado. Thank you very much. I'm going to try to move these. Okay. Well, good evening, everyone. And thank you for being a part of this. It's a very big honor and pleasure for me to participate. I want to thank Marcelo for inviting me to participate in this webinar. I always enjoy any opportunity to speak about the scapholunate ligament. And I also really enjoy speaking to my friends from Brazil. I've had many nice encounters and visits to Brazil, as Marcelo pointed out, including this visit, or including this time in Fortaleza 2 years ago at the Brazilian Society meeting, which was a wonderful event chaired by Marcelo. So I really enjoy our friendships, and I enjoy speaking with all of you, and our not only our social relationships, but also our professional and educational relationships as well. This is where I'm from, again, Stanford University. This is my email address. Should any questions arise, happy to speak to you or answer any questions during this webinar, or also via the internet if you would like. Also, we often have visitors, and we've had a couple of visitors from Brazil come to visit us at Stanford as clinical scholars and came to visit us to observe. So if you're interested in that, please feel free to contact me as well. Okay, so I'll skip all the basic things about the scapholunate ligament. I think we're all familiar with that. So I'll go right towards our pathologic conditions. This is widely accepted, the categories of pathologic conditions that we see with scapholunate ligament injuries. And I'll go through basically the first 2 or 3. I won't really focus on the slack wrist. That's a different discussion altogether. And primarily, arthroscopy is not very, can be used for the slack wrist. There have a PRC and scaphoid excision 4-corner fusion has been described via arthroscopic technique, but I won't focus on this during this discussion. So I'd like to share with you my thoughts on the treatment of the pre-dynamic and dynamic instability patterns. Initially, the treatment is with activity modification for our patients in California. We have a lot of patients who like to do yoga, push-ups, weightlifting, etc. And the avoidance of the wrist hyperextension and axial loading often can help, as well as the mobilization for low-grade scapholunate ligament injuries. Corticosteroid injections can help with some synovitis and the dorsal wrist impingement-like syndromes. But ultimately, if this all fails, then we talk about surgery. And I think this is the best indication for arthroscopy when discussing the scapholunate ligament before the ligament's completely disrupted. So here we have, to demonstrate this, a 22-year-old football player. This would be American football with dorsal central wrist pain. The radiographs are not particularly telling. However, on MRI, you can see the dorsal scapholunate ligament has been ruptured, or at least partially ruptured. And on arthroscopy, you can see this is a mid-carpal arthroscopy. And so we could see the scaphoids on the left and the lunate is on the right. I have an instrument through the ulnar midcarpal portal demonstrating the dissociation between the scaphoid and lunate, viewed via the radial midcarpal portal directly down onto the scapholunate interval. And what you can see in the background, hopefully you can see my pointer, this is the volar scapholunate ligament here. In fact, here we can actually see the radioscaphocapitate ligament running through here. Marcelo, I don't know if you have audio, but can you see my pointer?
Yes, we are seeing.
Yes, that's okay.
Yes.
Great.
Yeah,
Great.
I see it.
Great. So this is the
Yes,
So this is the radioscaphocapitate ligament going from the radial stylite across the waist of the scaphoid and to attach to the capitate. And this is the volar volar scapholunate ligament, scaphoid here, lunate here, and here's the gap. So I'm fond of the Geisler classification of these tears. It's what I trained on and what I use routinely. There is an EWAS classification as well. But suffice it to say, this is graded based on the level of instability, with a higher level of instability indicating a higher grade. And so in this situation, in this patient's mid-carpal arthroscopy, this can be considered Geisler grade 3 injury. And this is the EWAS classification, also serendipitously a grade 3 stage of ligament injury. So when it comes to treatment of these injuries, I'm very fond of debridement of the loose, unstable ligament, as well as thermal shrinkage. And I'll get to more of thermal shrinkage in a moment. Now, we also add pinning if there's a higher grade level of instability, particularly a Geisler grade 3. So I want to emphasize that this is the pathology we're talking about. The ligament, is, if it were this rubber band, is just being stretched. It's not completely ruptured. So as such, there's still some ligament substance to heal itself. So it's kind of delaminated and stretched out rather than actually ruptured. And so shrinkage has been somewhat vilified in the orthopedic literature, particularly in the shoulder literature, mostly because it's failed, thermal shrinkage has failed in the shoulder. And the reason for that I'll discuss in a moment. In the wrist, however, I think it has a very good indication. So here would be the ligament. There's the volar ligament there being shown before and after the thermal treatment. And the way this works is it restores stability by thermally shrinking the collagen. We believe this also leads to some secondary fibroplasia and scarring. We also believe that there's a denervation effect, and I'll get to that more in a moment as well. The results are poor in the shoulder, but excellent in the wrist. The way this works, and this is again from the sports medicine literature, is that type 1 collagen is really made up of collagen fibrils organized in a triple helix linked by 2 types of covalent bonds. We have heat labile bonds and heat stable bonds. The heat labile bonds are the bonds that are broken with the thermal treatment, and the heat stable bonds remain intact. So when the heating disrupts the heat labile bonds, the fact that the heat stable bonds are still intact, there's a net shrinkage. And I tell people that it's sort of like taking a piece of meat and putting it on a grill or something, and it shrinks. And so the residual tension causes that to shrink, and the heat labile bonds will then reform themselves over the course of 6 weeks. And this is why it failed in the shoulder, because in the shoulder, you can't immobilize a patient for 6 weeks. Otherwise, their shoulder will never move again. So because you need that 6 weeks for that collagen to mature, and that's how it works in the wrist, because we can actually cast the patient for 6 weeks and allow that collagen to mature and then start therapy thereafter. So this is what it would look like before. And then in this case, we pin the joint. You could see arthroscopic assisted. We reduce the scaphoid and lunate interval, and we place K-wires percutaneously to hold the interval and then perform the shrinkage. We also believe there's a denervation effect by the thermal treatment. We did this showed this in our laboratory, where we added the thermal treatment to the ligament and then stained the ligament for neuronal markers, and we found that there was a paucity of neuronal markers in the area where the ligament was treated. Clinical results, there's many different results out there, most of them short-term, 2 years, roughly 2 years. This is a study we published with longer follow-up, 7-year follow-up, Geisler stages 1 through 3, all treated with thermal shrinkage, and we see the outcomes are quite good. And most importantly, none of these patients required any subsequent surgery. So I do believe that this is a very effective treatment modality for the lower grade ligament injuries where the ligament's not completely ruptured. Obviously, if it's completely ruptured, then there's nothing to shrink back together. But when it's partially ruptured, this is a very effective treatment. And this is that patient, 22-year-old, 5 months after surgery with near full range of motion. So again, my algorithm for these injuries, and this, quite frankly, is one of the most common patients that I see in my practice. Patients, they don't have a complete ligament injury, but they have dorsal wrist pain, particularly with hyperextension, doing a push-up or yoga. I usually try to immobilize them for 4 weeks, modify their activity, inject some steroids, and if that all fails and the MRI is consistent with a partial ligament injury, then I do think that wrist arthroscopy has excellent indication with the thermal shrinkage plus or minus pinning. And we've shown that in our clinical studies. What about moving on to static instability? This requires more than a partial rupture, but a complete rupture of the scapholinea ligament, as well as potentially the secondary stabilizers. Here's a 40-year-old patient fell from a bike. Now here on the X-ray, we can clearly see, this is not a grip view, but you can clearly see on a standard static PA radiograph, you can see the gapping between the scaphoid and lunate. And again, don't necessarily need an MRI in this situation, but there you can see the gap on MRI. And with the wrist arthroscopy, you can see there's a complete widened interval between the scaphoid and lunate. This is what we call the drive-through sign, and where we can drive through with the scope between the scaphoid and lunate and visualize the capitate, which is right in the center of the screen right here, as the scope is visualizing through from the radiocarpal joint. Once you have a complete scapholunate ligament injury with the gap, this is from the EWAS classification stage 4, as well as the Geisler classification of stage 4 as well. In this case, most of the time, we'll treat these with an open suture anchor repair. And this is what you can see here. We usually insert a suture anchor in the scaphoid or lunate, wherever it's ruptured from. Insert some K-wires between the scaphoid and lunate to stabilize that interval, a scaphocapitate pin for additional stability to help prevent scaphoid flexion and repair the ligament. However, a few years ago, we published a technique of arthroscopic repair of a complete scapholunate interosseous ligament. First, we wanted to show anatomic feasibility. So we wanted to see and show that we could definitively see the dorsal scapholunate ligament from the radiocarpal joint using standard arthroscopy portals. So we looked at 10 fresh frozen cadavers. We used this arthroscopy tower in neutral position, normal gentle traction. We used a standard arthroscope. We used the standard 4-5 portal, and we made an attempt to visualize as dorsally as possible the dorsal scapholunate ligament. We inserted a K-wire from the standard 3-4 portal into the scaphoid adjacent to the most dorsal portion of the ligament visualized. We didn't do any extra maneuvers, didn't have to flex the wrist or anything. So basically we're visualizing the ligament, putting a K-wire through under arthroscopic visualization. And then what we did is we dissected the cadaver to see where that K-wire was relative to the dorsal scapholunate ligament, the most important structural portion of the ligament, which had ruptured, to basically see if we can actually get to the footprint from where these ligaments typically avulse. And here you can see a cadaveric specimen. You can see the K-wire has been placed here. This is the dorsal ridge from which the scapholunate ligament usually attaches. And you can see clearly, we can see far enough dorsally to identify the footprint of the scapholunate ligament. We also identified this prominence from which the scapholunate ligament typically attaches. Again, this shows that we were clearly had plenty of space. So what this basically showed us is that we had enough space to actually perform a procedure. We could see where the ligament was ruptured from using standard portals, and then we could actually do the procedure. And so that's basically what we concluded, that we could actually see these structures. And so the technique of the repair, this video plays, here we go. Here's the standard 4-5 viewing portal. And then the 3-4 portal. This is where we would be passing our suture and inserting our anchor. Now this would be using its knotless anchor. And we use an accessory 1-2 portal for shuttling the suture. So what I'm demonstrating here is the scapholunate ligament, the scaphoid's in the background. I'm using a knife to basically cut the ligament iatrogenically. This is an open specimen to just show what we're doing. And then this is a suture passer. We pass the suture via the 3-4 portal through the substance of the scapholunate ligament. And this is the instrument being demonstrated here. There's this scapholunate ligament there. And passing it through the substance of the scapholunate ligament, and then harvest it after it's passed through the suture passer. Once we harvest that, then we pull it out through the 1-2 portal, accessory portal, and then retrieve it back through the 3-4 portal. As you can see here, we're grabbing it through the 3-4 portal. Now we have both limbs through the 3-4 portal. We insert a slotted cannula through the 3-4 portal, put this on that spot on the dorsal scaphoid from which the ligament's been ruptured. And now we're loading the knotless anchor with the suture. And you can see the suture has the bite in the ligament. We drill through that cannula, our pilot hole for the anchor, into the scaphoid. There you can see the drill going. And you see the two limbs of the suture pass through this knotless anchor. Again, these are just open images just to show you what we're doing arthroscopically, because it doesn't always make sense what you're looking at arthroscopically. Now it's being inserted into the scaphoid. And because it's knotless, all you have to do is impact the anchor into the scaphoid, and that completes your repair. And once you get down to the laser line there, then you know you're deep enough. You could see the suture through the scapholunate ligament. You could see the amount of tension that's on the ligament. And then you could see the final repair there. And that's what it would look like when it was completed. So we immobilize our patients for with 262 C wires for about 8 weeks, and then we start therapy. What we found that this is definitely feasible, but it is technically demanding. So this was published several years ago, but it hasn't really gotten that much popularity because it is technically challenging. And most people, especially even your more skilled arthroscopists, feel more comfortable just opening these and fixing them via an open approach. But it is possible using an arthroscopic technique if you prefer. What about the chronic scapholunate ligament injuries where it's static, you have a DZ, and there's no arthritis? The Garcia-Elias classification would be grade 3 or 4. It's reducible, but there's no arthritis, but there's no ligament to repair. Again, the EWAS classification, class 4. In this situation, there's many different options: capsulodesis, ligament reconstructions, many bone ligament bone autograft procedures, Razzle procedures. There's many different options, and then there's also the salvage procedures, which I initially discussed, PRC or partial wrist fusion. Capsulodesis procedures, most of these are obviously being done open with decent results. However, Christophe Matulin has shown a arthroscopic method of treating these with an arthroscopic capsulodesis, and basically the entire theory is based upon the fact that, again, the prominent role for scapholunate stability is not only the dorsal scapholunate ligament, but the dorsal radiocarpal ligament and the dorsal intercarpal ligament, as well as what he calls the dorsal capsuloscapholunate septum, or DCSS, which also provides stability. So the thought is that you can, if you capsulodese all those structures together, that can help stabilize the scapholunate interval. And also, more importantly, as we've learned, that the primary pathology with scapholunate dissociation is dorsal subluxation of the proximal pole of the scaphoid. And so what these dorsal capsulodesis procedures do is it keeps the scaphoid buttressed from escaping dorsally. And that's why they work, even though radiographically sometimes you see the gap between the scaphoid and the lunate persists. But as long as the scaphoid is maintained in the scaphoid facet and does not abnormally wear on the scaphoid facet, you prevent those sequelae of the slack wrist. And so this is the procedure that Christophe published upon, which is very elegant procedure. At first glance, it looks somewhat unbelievable, but I'll tell you that now, after doing several of these in my own patients, I'm a believer of this technique. It's surprisingly powerful. So here's one where the ligament's completely disrupted, and you can see needles are placed through both limbs of the ligament, and then a knot is tied between the two sutures. The knot then is placed both on either side of the capsule. You can see in this lower figure here, and that's your capsulodesis. So here's one of my patients, Geisler grade 3, a little bit greater of a dissociation than the one I showed earlier, which I treated with thermal shrinkage. So you can see the gap between the scaphoid and lunate. And so I'm placing the needles through the ligament. So again, the scope is in the 4-5 portal. The needles are going through, piercing the ligament through the 3-4 portal. And then we harvest now we're in the midcarpal joint where we see both needles through the ligament. And we pass the suture outside the joint, tie a knot, pass the knots back through, and you can see the knot in the lower right-hand corner stabilizing from the intra-articular portion. Then you'll have your 2 knots on the other side. Actually, this is going to show as I pull the knot into the joint, that's securing our dorsal scapholunate interval down to the dorsal capsule. You can see the knot there. And let's see, it should advance shortly. Now you can see as I pull on the sutures, that gap closes. I haven't tied the knot yet, but as I pull on the suture, the gap between the scaphoid and lunate closes. So it's surprisingly effective. There, it's open again. And then in a moment, we'll pull on the sutures again to tighten that up. So I'm grabbing the sutures now and I'm pulling on them. You can see the gap close like that. And then I can't get my probe back in there. So it's surprisingly powerful. I was a little bit skeptical when I first saw it, but after doing it now several times, I'm a big believer in this technique. And so you could see before the gap is open, and after the capsule desis, after the knot is closed, tied, the gap is closed. Other options, again, bone ligament bone or ligament reconstructions. I think worldwide, the gold standard remains modified Brunelli 3LT ligament tenodesis technique described by Mark Arcelius and John Stanley. But the concern here is with these dorsal ligament reconstructions is this situation where it looks pretty good. This is one of my patients I did a 3LT on, looks pretty good initially. And then after 6 months, you could see the gap recurs. Now this patient did okay. And again, I think it's because we're preventing that dorsal subluxation of the scaphoid. The gap between the scaphoid and lunate, I think, is a little less of an issue. But it does make for an ugly x-ray. So the question is this okay if we're dorsally reconstructing the ligament, but neglecting the volar side of the ligament and we're having gapping volarly? The Rassel procedure and the 3LT, the SLT procedures are similar, what we call axis procedures, where we're trying to reconstruct the scapholunate interval via the axis of rotation. So here, this is using a metal screw, but we describe this the so-called SLAM procedure, or scapholunate axis method, of using a tendon graft instead of a screw, passing between the scaphoid and lunate and anchored within the lunate with an anchor into the scaphoid. It's sort of like an ACL of the wrist, if you will. And then the remaining graft would be passed dorsally to reconstruct the all-important dorsal scapholunate ligament. And we presented published our results with 13 patients with mean follow-up of only 11 months, but you can see their gap decreased and their scapholunate angle also decreased significantly. So to summarize, my algorithm in 2020 for scapholunate dissociation for predynamic injuries, which are the most common issues, dorsal wrist pain, etc. I like to immobilize, modify my activity, inject with steroids, and then if that fails, arthroscopic surgery with thermal shrinkage plus or minus pinning. I think it's very effective. Acute dissociations that are less than 8 weeks old, I think an open repair is performed, or you can perform the arthroscopic technique I presented, or even the Matulin capsulodesis technique in acute injuries. But I think most people would probably favor an open repair in that situation. And then in the chronic, with arthritis, it's pretty clear. We know that we have denervation procedures, arthroscopic debridement, radial styloidectomy, and then SLAC2, you're looking at a PRC, and SLAC3, you're looking at a scaphoid excision 4-corner fusion. And then the remaining issue that becomes debated quite frequently is the subacute, where the ligament's no longer repairable, usually after 8 weeks of injury, but there's no arthritis. And that's where there's a number of different techniques, as I showed you. I do favor the Matul encapsulodesis in that situation, or if it's particularly bad, I do like the SLAM procedure. Obviously, I'm biased, or the modified Brunelli 3LT procedure, or there may be a new technique down the road that becomes more reliable. So with that, I know I'm about 30 minutes. I'd like to thank you, Obrigado, for your attention. And I'm happy to take any questions either before the cases or after the cases.
Okay, thank you, Jeffrey. James, do you have any questions in the chat?
No questions at this moment, but we started to discuss these cases first.
I would like, maybe I have a question for Jeffrey. Jeffrey,
yes.
You talk about the type 3, the acute dislocation, that you prefer to use open repair. The question is, when you do, we here in Brazil, like there was some group in Italians, we began to use a double view, a dorsal and a volar view, to make the volar repair of the ligament. And it seems to be more tight, you don't see, when you took out the Kirchner wise, you don't have the opening, and that seems to be very nice. So, but double view is a little bit freaky, and then we began to put the anchor, a dorsal anchor, and an anchor in the middle, and a more membranous portion of the ligament, and it works. It works. We put 2 anchors, open repair and so on, and put 2 anchors on a dorsal aspect and in the middle aspect, because it's too difficult to reach on a volar side by dorsal side. And then it's a very good way to perform. It doesn't open. It maintains clearly. Yeah.
So that's a one approach, a dorsal approach, 2 anchors. Yeah, so that's typically what I would do as well with my repairs. I would put 2 anchors, depending how large the tear is, but assuming it's completely ruptured, I do 2 anchors. You can argue that the membranous portion does not have a huge amount of structural stability, and so repairing that might not provide much extra benefit. But I think these anchors are pretty low profile, and adding an additional one doesn't necessarily hurt anything. I think the volar approach is very attractive, and especially with reconstruction, a lot of reconstructive techniques that use this 360 concept or box concept of doing dorsal to volar kind of reconstruction.
PC hose,
yeah, PC hose technique, exactly. And there are other techniques as well, where again, we're trying to reconstruct the entire construct, not just dorsally. We understand that the dorsal scapholunate ligament is the most structurally sound and most important. But if we neglect the volar side, then we could still have some gapping, as I showed in that crude cartoon. But then again, the question is especially with those 3LT patients, where they're still gapping volarly, and they're gapping on X-rays, those patients still do okay. They do well clinically. The range of motion is quite good, at least 70%, strength over 70%, and most importantly, no degradation to a slack wrist. And so, again, as long as I think you prevent that dorsal subluxation of the scaphoid to abnormally wear on the radius, then that prevents the progression of the arthritis. And that's really what we're trying to do here. And that's why the black capsulodesis also worked well also, right? Because the black capsulodesis does nothing about the gap. It just prevents that scaphoid from flexing, but also prevents it from dorsally subluxating. But none of this is purely anatomic, of course, but I think we continue to learn about this pathology and learn newer ways and better ways to treat it.
Jeffrey, maybe I missed something about the Matul techniques. What is the indication for? Is just for not for complete injury, I guess.
He does it for complete injuries. He does it for complete injuries. My perfect patient for that
Partially.
is where it's partially torn, but it's a high grade partial. So 70, 80, 90%, because there's still some connection between the scaphoid and lunate, and that capsulodesis is just tightening it, but also performing that capsule, bringing the capsular tissues down to the ligament to help provide that stability. That's the perfect, in my mind, indication. Now he'll do it for grade 4, where it's completely disrupted. As long as there's a little bit of ligament on either side, and that he can get a needle into, he will still do it for that. For me, I think it's harder for me to really believe that would provide as much stability as one of these more larger reconstructions that we talked about briefly. Again, this wasn't a talk really focusing on reconstruction. I know one of your cases discusses that. But for arthroscopic, he does do it for those patients, but I like it for those really bad grade 3 where it's not shrinkable because it's more than 50% partially torn, let's say. Less than 50%, I think they'll do the shrinkage, and more than that, I'll do this capsulodesis, and I've been very pleased with that technique.
Okay. I have another question.
Let me share. We have 3 cases, and let's start to discuss. And during the discussion, probably we are going to have more questions about your lecture. I'm going to share my screen. James, is there any question in the chat?
Not yet, because I believe that Jeffrey have answered most of the questions that we have now. Just one question: how difficult is to suture the ligament attached in the lunate with the suture pass? Because we know that it's not a gentle instrument. So someone like to know if you have some difficulty to have this suture arthroscopically.
So are you talking about the technique that I showed with the anchor, or the Matulin technique? Oh, I'll answer for both. So absolutely for both. As you know, sometimes you get in there and that ligament is really small, number one. Number two, friable. It's you put a suture in, it just rips right through. And in that situation, it's very difficult to do any of these suture repairs. And I think you're looking at a reconstruction. That usually happens several weeks after the injury. If it's an acute injury and you're there within a couple of weeks, 1 to 2 weeks or 3 weeks after the injury, the ligament usually has good strength. And so either of those techniques where you're using a suture passer to pass through the ligament, I think is certainly possible. Now, for both of those techniques, I always tell the patient beforehand that there's a possibility that while we're doing this, we can't perform the arthroscopic technique because the ligament quality is not good enough, and then we have to have the patient's permission to move forward with an open technique, open reconstruction. Luckily, I haven't had to do that frequently. Usually, there's a decent enough tissue to repair.
Okay,
Jeffrey. Okay. Just the last question now. The last question is: what about just the breathing and refreshing the ligament and just pinning with the scope? What's your opinion about that? This technique?
Thermal linkage.
Sorry,
James, could you repeat?
Okay, my question, or the question of the audience is: what about, or what is your opinion about to just the Bridgman, refreshing the ligament and pinning with a scope?
So
closed procedure.
Closed completely. I think that's a very interesting technique, and there's been some working from Korea, from Minjung Park's group, particularly in the case of a perilunate injury, just arthroscopically debriding and pinning, and those patients did well. I'm a little bit concerned about this situation, about that having enough biology to heal and provide enough stability. I agree the quality of the tissue is often not that great when you're putting suture anchors in there, but there's usually enough to provide some attachment of the ligament from the scaphoid to the lunate, so that there is some biology, some ligament that could potentially heal. I decorticate the bone from which it's been avulsed, so there's some blood there. some stem cells that potentially can augment the healing as well. So ultimately, I do think that that makes me feel better. To think that that would be more biologically sound than just debriding and pinning. But there is a precedent of, like I said, the group from Korea that just does that. Now, this is a perilunate situation. So there's both of the ligaments are disrupted, on both sides. So the scapholunate and the lunate triquetral ligament. So there's not that opposing force of the intact LT ligament pulling on the lunate away from the scaphoid. So that may be why in the perilunate situation it works better or it works okay. I just don't know, and I don't know that the work has been done in a primary scapholunate ligament alone. I'm not aware of any. There could be. So it just doesn't provide me with the same amount of confidence that I'm doing the best possible thing for the patient.
Okay, so let's start the discussion of the case, clinical case. This is the first one, is a chronic scapholunate, maybe still acute according to your classification, maybe. So this is a 46 years old, a male, personal trainer. He fell down over the right hand in a supination position, riding a bicycle 2 months ago. He was attended in an emergency room after the x-ray was oriented to use the wrist splint for 2 weeks. Had a persistent pain after the beginning of his regular activity as a personal trainer. And my initial evaluation was 4 months after the injury. He had a pain in the radial side of the wrist. There are clunk sign when you did the Watson maneuver, and weakness of grip strength. Here is the x-rays, is the right side, the D, right side, and the left side. Maybe the x-ray is not so obvious, the lesion. Even the angle, maybe we have some questions. We can understand why, maybe why our colleague in the first attendance didn't realize the injury. Here, but when I ordered MRI, and we can see in the different views, a very complete injury of the scapholunate ligament. In axial view, it's a better view to see this injury. So this is the X-ray, the intraoperative view. We can see the debris of the ligament. Here we are going to see in the right side the lunate here, and then we go to the radial side and see the injury, the gap. Here is the scaphoid.
Pois não?
Here is
Oi, Ramalho, como é que você tá? Tudo bem?
Rames, here we see the gap
sim.
in the middle. Sorry, there is a. Here we can see the opening of the injury, the joysticks showing the instability of the scapholunate after the fixation. So I'm going to show the X-ray with the procedure that we did. So we did the anchors. The level of the injury was different. Part was the ligament was in the lunate and part in the scaphoid. That's why we put 2 anchors. And we did a pin, put a pin to scaphoid captate to stabilize the scaphoid. And then we put a screw between the scaphoid and lunate. It's a temporary screw. Maybe we have some questions about concerns about the position of the screw. Maybe later you can talk about that, Jeffrey. So the follow-up, the patient was kept in a wrist splint for 70 days, orientation to avoid the use in hand in daily activities. After 70 days, we removed the key wire and also the screw, and started the rehabilitation process. This is when we removed the pin and the screw. It's an intraoperative view. We had the sensation that was stable, the relation between the scaphoid and the lunate. Here is after 5 months, the follow-up, and still can see that there is no opening between the scaphoid and lunate. And here is after 5 months, the range of motion is the right side, the problem of the patient, the right one. So good range of motion, and was back to his job as a personal trainer. Jeffrey, I have some questions about this. I would like you answer. The first one, how often are your cases of scapholunate acute or chronic? How often? Usually they comes to you as acute case or chronic ones?
So you're talking complete ligament injuries, right, Marcelo?
Yeah,
here?
yeah.
So unfortunately, I would say probably 80% of our injuries are more than acute. So I use 6 weeks as my cutoff, 6 to 8 weeks as my cutoff for acute versus chronic. So probably 80% are beyond 6 to 8 weeks. Only 20% are in that 6 to 8 week window. And the reason I say unfortunately is because if it's within that 6 to 8 week window, I think that ligament is much more robust, as we talked about. And I think it's the ability to acutely repair that is much higher than when it's beyond 8 weeks. So that's why I found it interesting that you saw this patient 4 months after their injury, if I understand correctly. Is that right? 4 months?
2 months.
2 months.
2 months. Yeah.
Okay. Right. So I agree. We have this discussion in the US as well. Some people think that after 6 weeks, there's nothing left to repair. I find that I've had good success repairing ligaments up to 10 weeks. I always tell patients 6 weeks just in case, but I've been pleasantly surprised when we go in there 10 weeks later and we could still see there's ligament to repair. So,
and
anyway.
what about the use of screw, like I did? But I
like
use
that
it just for 2 weeks, 2 months, maybe a little bit more, 2 months. And then I remove.
No, I like that technique a lot. I used to do it all the time. I usually use a headed screw. I saw you use a headless screw. I usually use a headed screw so that
remove.
I can, right, easier to remove. But it's still difficult to remove because finding that tiny hole with your guide wire in the head of the screw is very difficult sometimes, and it's frustrating. So I've stopped doing it just for that reason. I think the fixation you get is great. I usually do it for 3 months. And the beauty of that is I don't use a secondary scaphocapitate pin. So if you just have one screw there, you can start dart throwing motion. You can start regular motion immediately. And then at 3 months, then go back, remove the screw, and then that they're a little bit ahead of the game in terms of range of motion. So I think that I really love that option. I just don't do it anymore as frequently just because it's just a headache trying to take that screw out sometimes.
I agree totally with you. I agree totally with you. I don't like it. I don't like it at all.
Do you think that the ligament repair is enough to guarantee the good results in a long follow-up? Or as I'm saying, a good ligament repair, it's just what we need to have a good result?
Yeah, so I think this goes back to Alvaro's question, which is a very good question, is do we really think that repairing the ligament alone is really providing the stability that we need here? And I do think that if you have good quality ligament, which it appeared that you did in your example, I think putting an anchor in there and sewing the ligament is still the standard of care and the best thing to do. But what I'll do is I'll also perform the capsulodesis on top. I'll bring the dorsal capsule down to the ligament, basically the same sutures that I have that I repaired the ligament. I don't cut the knot. I don't cut the sutures after I repair the ligament. I leave the sutures so that I can use the same sutures to bring the capsule down to the dorsum of the scapholunate ligament to augment and reinforce the repair. And I do think that the combination of the two is what provides me with the robust or the good outcomes that I've seen in my patients.
Yeah, and the professional activity is a factor to indicate the type of reconstruction or not, like athletes.
Yeah, so athletes, absolutely. I'm much more aggressive with athletes. I tend to favor repairing even patients that are grade 3, I like to repair to provide the additional stability. Whereas non-professional athletes, or even just office workers or people that don't put an extreme amount of load on the wrist, I think you can be a little bit more relaxed and not as aggressive with the treatment type.
Okay. James, do you have any questions in the chat or not?
No. We can continue
No.
for the next case.
So the second case, Dr. Tiago Matar is going to present. So, Tiago.
Okay. Hello.
Go ahead.
Good night to all. My name is Tiago Matar, and I'm going to present you this case. Próximo. The case is about a patient with 27 years old. He was of male gender. He presented himself with a pain in the wrist after trauma. He had a progressive worsening of the wrist function 6 days ago. Because of the clinical presentation, we asked for a wrist MRI and a wrist X-ray, and these are the results. On the X-ray, we could identify presence of a positive teratoma sign or a gap of more than 3 millimeters between the scaphoid and the lunate, and the presence of carpal instability with increased scapholunate angle and demonstrating like gross instability. On the MRI, we could identify a dizzy deformity and the presence of a complete scapholunate ligament injury. So because of these finds and the gross instability, we decided to do an open repair of the scapholunate complete injury. This is the incision that we made. We did like a normal incision and opened the third and fourth extensor compartment, opened the capsule, and identified the lesion of the ligaments. Next. This is a video. So here we can find the ligament attached to the lunate and rupture on the scaphoid and a very big gap between the two bones. And we were planning the insertion of the anchors in the scaphoid. Next. So we began by inserting like a corkscrew anchor in the more volar aspect of the scaphoid. Next. And then we introduced a second corkscrew anchor on the more dorsal aspect of the scaphoid. In that way, we were aiming to repair both the volar portion and the dorsal portion. We know that by the dorsal incision, we can access completely the volar portion, but we were trying to get the most volar possible. And then we do using K-wires, we made a joystick so we can reduce the diastasis between the two bones. And then after reduction, we do the suture of the ligaments. Next. This is a video. We are introducing the more dorsal anchor of the scaphoid. Next. What we did different in this case is that after we did the repair with the two corkscrew anchor, we also did a technique of internal bracing with a swivel lock, DX anchor, and fiber tape. We actually use 3 swivel locked anchors and a fiber tape, one in the lunate and the other 2 in the scaphoid. Next. And we use the corkscrew anchor we used to repair the ligament. We also use it to, like Dr. Jeffrey was just mentioned, we used to do the capsulodizes. We use the same suture of the ligaments to repair the capsule. Next. We also use just one K-wire to fix the capitate with the scaphoids to add more stability. Here we can see a good reduction. And in this video, I would like to just show the technique of the internal bracing here. We can see one of the strips of the fiber tape and the 2 anchor swivel lock anchor on the lunate and the scaphoid. After that, we create a second strip of the fiber tape. And after introduction of a swivel lock anchor on the distal portion of the scaphoid, we can add more stability. Next. And after the repair, we checked the stability. And we can see that we have a very good reduction of the scaphoid and the lunate, and with no gaps, and we could test, and we were very satisfied with the results. We know that this is a very new technique. This was our first case, so I had some questions to Dr. Jeffrey about this case. My first one is that considering the gross instability, would he be able to do an arthroscopic repair in this case?
I'm so sorry. Part of the problem with being in the mountains is I lost internet access for a while, so I missed part of the presentation, but I do believe I caught most of it, which was you had an anchor in the dorsal scapholunate and an anchor in the remnants portion, repair that, augmented with the internal brace. Is that correct?
Yes, yes. We are mainly showing this case because of the internal bracing using swivel lock anchors. And I was starting to ask you just first question is that in these cases of gross instability, in this particular case, would you do an arthroscopic repair or an open repair?
So when there's evidence of a DZ deformity, I think at that point it's very difficult, if not impossible, to do that arthroscopically. And in this case, there appears to be a DZ deformity. So I would have preferred an open approach here, and I would have done the same thing that you did up until the internal brace. Now, I don't have anything problem with the internal brace. I think it's a very robust reconstruction and very attractive option. I have two concerns of using the internal brace. Number one, this fiber tape is now intra-articular, right? So it will articulate with the dorsal portion of the radius. And I wonder if over time that will cause some damage to the articular cartilage of on the radial side. I don't know the answer to that, but that's one concern I have. The second concern is that, as you can see, these are 3.5 millimeter swivel lock anchors. And so there's a large drill hole that is placed into both the scaphoid and lunate. And so I worry, and in fact, we're starting to see some patients with radiolucency around the anchors radiographically, as well as some potential concern for avascular necrosis, particularly of the lunate because of the amount of dissection initially dorsally, and then you're drilling into the lunate, a relatively large anchor. And then plus we don't know over time that the forces on that fiber tape, how that will affect the biomechanics of the scapholunate interval. So I'm just cautious. I do think it's a very robust, it provides immediate robust stability. There's no question about that. But those are just my two concerns of that technique for those reasons. Now, on the other hand, I think it's a very good technique for reconstructing the thumb UCL, the MCP ulnar collateral ligament. That is extra articular, so I don't have any issues with having that reconstruction augmented using the internal brace. But I have seen, again, some of those lucency around the anchors in the base of the proximal phalanx and the head of the carpal in those situations that give me a little bit of concern. But I think this is a beautiful result. This patient, I'm sure, will do very well, but I just worry. Those are the two things that I worry about. And I'd love to see 10 years, 15 years down the road that these patients still are doing great. And in that case, I'll use it every time.
That was my second and probably third and fourth question. I think you answered most of them, but your main concern is about the vascularization of the scaphoid, or maybe the chances of bone fracture, or the problem is the fiber tape of the fiber tape being in an interarticular position.
I think probably that the fiber tape being interarticular bothers me more. I think there's plenty of precedent of having large drill holes in the scaphoid and lunate and it being okay.
Do you have any experience with these fiber tapes in any application, or maybe in different parts of the hand surgery? Like
not interarticular, and that's why I'm concerned, because I don't know, and I don't know that anybody knows how that it'll be long term, and I think we'll see 5 years or 10 years down the road whether or not it's a problem or not. I may be overreacting and it may be totally fine, and hopefully it is totally fine. And if that's the case, then like I said, I'll use it every time. But until I see that data, I have enough concern, and I think there are a number of other good options that I currently use so that I don't necessarily use it for this. Again, I don't think you did anything wrong. I just those are my concerns as to why I haven't adopted this technique.
Okay, Thiago.
Okay. Yep.
Okay. Edgar, please.
Okay.
Olá,
Good
Edgar.
evening, everyone. Jeffrey, it's a pleasure to see you. We've
Yeah.
met last year in Minnesota in a WIS course there,
That's right.
and asked you to organize a course like that in California. That is a little bit warm than Minnesota.
Yeah.
Okay.
We would love to.
I'll present a case of a young boy, a 18 years old boy. He had a previous syndrome, it's Ehlers-Danlos syndrome, a ligament laxity, very serious case with previous ankle surgeries, repetitive sprain, a lot of pain into the right wrist, and recent a worsening of pain of trauma playing volleyball. My screen is closed here. So this is the clinics. If you can hear, there's a clock. It's you can hear the clock when he moves the wrist. It's not sound, I can hear, but if you can hear the click and the clunk of the wrist. And here, when you try to move, flex and extended, ulnar and radial deviation. Did you notice the click and clunk? It's painful and audible, and very difficult to do the active living things like studying, eating, putting clothes. It's very disturbing. During the examination, when we stabilize the pisiform and trichotrum, there is improvement in the click and pen. It was described in many articles. The article that I like the most is the PCHO article that they describe this technique to stabilize the ulnar wrist part to improve the click and pen. And it happens with this boy. So, Marcelo, I think you can move on. This is the X-ray. I actually didn't see anything most important. Maybe a little VZ situation of this wrist, but I don't think we can trust in this X-ray. It's very similar. This is the contralateral side in the bottom part of the screen, but it's very normal to me. And in the next, in the MRI, no apparent ligament injury, a little bit of synovitis, and I don't know if Jeffrey agrees with me. The dorsal ligament, no, come on. The dorsal ligament is a little bit step off from bones. I don't think there are capsular redundancy, and it's difficult to see, but maybe. And when you see lunate, maybe there is a irregularity of the lunate in the bottom part, volar part of the lunate. But I don't think it's, you can trust, but it's a pretty normal MRI, and I don't, maybe Jeffrey can see. Okay, now what? There are a lot of situations regarding metacarpal instability, especially in a very young boy with Ehlers-Danlos syndrome. I'd like to hear from Jeffrey, what would be your treatment options for this case, please?
Okay, thank you for that case. Perhaps we can go back to the MRI. Perfect, thank you. So it sounds like a classic example of midcarpal instability. I like the technique you showed, which is to stabilize the pisiform and pushing up on the pisiform that helps stabilize the pisotriquetral joint and helps stabilize the proximal row. Another technique that I like to do clinically is the midcarpal shift test, which is to basically load the wrist when the patient's making a fist and go from radial to ulnar deviation. And when the patient's going from radial to ulnar deviation, as the hamate articulates with the triquetrum, that helicoid articulation of the triquetral hamate joint will cause the proximal to flip and reduce. And so I like to do that to help confirm the diagnosis. And lastly, what I'll typically do is a cineradiography. So under live fluoroscopy, do the same midcarpal shift test or midcarpal clunk test, and under live X-ray fluoroscopy, visualize that. And that helps me confirm that, again, we're not dealing with our carpal instability, not a dissociative pattern, and that this is a carpal instability non-dissociative pattern, or a SIND midcarpal instability. And if that all bears out, and it looks like on your examination that's true, then the treatment is very challenging, as I'm sure you all know, and that's why this case is being presented. A couple of factors. Number one, midcarpal instability in general is difficult to treat, but add on top of that this patient is Ehlers-Danlos, and that makes it even more difficult. The other thing I would do prior to talking about treatment is also check the other side, because he is Ehlers-Danlos. He may have ligamentous laxity on his contralateral side, the asymptomatic side. And
he has, but less significant than the right side. It's
okay.
No pain, but it is a clink and clunk, but no pain. It didn't affect the daily living activities.
Great. So obviously for this, I would spend a lot of time to make sure I exhaust all non-surgical measures. I would immobilize the patient, cast the patient 4 to 6 weeks. I would do therapy. I would try steroid injections. I would do whatever I could to avoid surgery, because the typical treatments that I do for a non-Ehlers-Danlos patient with midcarpal instability, which works quite well, is arthroscopic, going in there again with thermal shrinkage. And I briefly showed the radioscaphal capitate ligament viewed on arthroscopy from the midcarpal joint. And if you look to the other side of the capitate, you'll see the ulnar capitate ligament coming from the other side. So they'll come from both sides and basically attach at this capitate at the same location. And that's called the arcuate ligament, when the radioscaphal capitate and the ulnar capitate ligament coalesce. And a great treatment for a non-Ehlers-Danlos patient would be to do thermal shrinkage of that ligament to stabilize the midcarpal joint. And I've done that in many non-Ehlers-Danlos patients, and they've done very well. Obviously, with Ehlers-Danlos, any procedure involving collagen is not going to work. It's going to stretch out again, and so that wouldn't be possible. Same with any soft tissue procedures, any soft tissue tenodesis procedures, things like that. I think it would be difficult to be confident that it would work in an Ehlers-Danlos patient. So if this patient truly failed all non-surgical measures, and I would try maybe a denervation procedure as well, AAN, PIN neurectomy, and if that all failed, then in my hands, I would probably favor doing a partial wrist fusion, a midcarpal fusion.
So this patient, we spend a lot of time doing therapy, doing orthosis, splintings, and even Botox, even toxin botulinum we use there. But no progress, the pain remains, and we have to move on and think about surgery with all concerns that you talk about bone fusion. Marcelo, pode voltar pouquinho? Marcelo, volta, por favor. There are many papers about midcarpal instability. These are ones that I base my decision-making process. The PC Ho paper about disease, dorsal application of midcarpal instability, and I liked it too much of this paper from Corella about volar central portal arthroscopy, and to close the interval between the four bone that from capitator, amator, lunate, and trichotrum. And you close this space with the arcade ligament, and also makes this more stable. This case I discussed with Toshi Nakamura and PC Hall there in Minneapolis. And each one has his own decision to it's not a simple situation. But Toshi Nakamura told me to do a dorsal application because of he told me about this capsule laxity, the dorsal capsule laxity that is very common in Ehlers-Danlos syndrome. And I keep that in mind to doing this case. So I did an arthroscopy, considering this is a young boy to do a bone fusion. So this is the 6R portal with a lot of synovitis, and you see the space, a normal, not usual space to see. So I palpating the ligament, interosseous scapholonate ligament, but it's a dry arthroscopy with a lot of synovitis. I try to clean the joint, bleeding a lot, so I pour water and saline when it starts to bleeding. It's very usual when you do that. Marcelo is going to put the arthroscopy in the metacarpal joint. I have no control of this movie, sorry, people. This is the debridation. Marcelo, pode pouco mais para frente. No instability from this point. Now we are in the metacarpal. You see it's a type 2 lunate, and the volar ligaments, the arcuate ligament, the metacarpal, capitated and lunated. I'll do a Corella incision in volar part of the wrist to make this volar central portal. And through this volar central portal, we see some Geisler instability in both bones, maybe type 3. I don't know if Jeff agrees, but I think in type 3, 2, or 3. This is the volar ligaments. So palpating the ulnar part of the arcuate ligament. And through this volar portal, I'll do the same. I cannot say this is a capsulodesis, but I try to close this space to give more stability in the volar part of the wrist. I'll show. There is a fragment, a cartilage fragment that I take it off. Marcelo, can you go? Okay. This is the volar volar portal. This is my prober from this volar portal. It's easily feasible. It's a very common technique of a loop made with nylon suture. And with a single suture, you can just close this space. I'm passing through the ligament. It's easy to understand, Jeff, for you. I don't know if you, okay. I'm closing that space. So the first part of surgery was to close that space. Of course, we have traction. And when you have traction, we don't see too very much this closing situation. But when you lose the traction, okay. I'm back again to the radial, the 6R portal. This is a anterior suture in lunate. And with this anterior suture, through the mini incision, I do the plicature of the dorsal capsule. It's like a Matulang technique with this suture, but I do this plication of the dorsal capsule. So I make this wrist stronger, or not able to move to as the motion we have after. So this is the 2K wires to stabilize the surgery. I kept these K wires for 6 weeks. So I took it off. It's after 6 months of surgery with a very good improvement of the clunk and clink and the pain. He start to study again, to write, to eat. It's a very good result. I don't know till when, because it's Ehlers-Danlos syndrome. We don't know how it lasts, but we can postpone a fusion. Maybe it's a good option for a young boy. It's my opinion and why I chose this technique for this case. I'd like to hear your opinion, Jeffrey. Thank you very much.
Thank you for sharing that case. I think that's a great case. Great result. As I said earlier, I'm always concerned with a patient with Ehlers-Danlos with any soft tissue procedure because I worry that over time it will stretch out. But that's a great result, and I hope that that result is persistent, that it continues to be good for the patient. Sometimes I think, yeah, fingers crossed. Sometimes I think that along what Alvaro said earlier, is that just tightening everything provides the stability, and it takes away that clunk, and that takes away the symptomatology, and hopefully that's been done. And like you said, there's no bridges that are burned, because if it fails, if it stretches out over time, he becomes symptomatic 2 years, 5 years, 10 years down the road, then you could always go to do a different procedure like a salvage or something else. So I think that's great. Thanks for sharing. So you basically imbricated both volar capsule and then dorsal capsule, correct?
Yeah. That's the idea. Volar and dorsal.
Yeah, that's really nice.
So I know we are too late. Yeah, Jeffrey, I promised that we would stop on 8 o'clock, but sorry.
No problem. I'm happy.
Ramis, is there any other question in the chat? Just the last one, maybe.
No. We don't have any questions.
Okay.
I believe that everything was answered.
Okay.
Thank you.
So Jeffrey, again, sorry to disturb you and your family, but was excellent. The discussion, your lecture was perfect. Okay. And I hope to see you soon.
Yes, that's my only regret, is that we can't do this in person, so I can't see you all in person. It's my pleasure to spend this hour with you. I really enjoyed it. I learned a lot, and I hopefully contributed as well. And I hope you all stay safe. You know, we were talking about how the cases in Brazil are concerning, just like in the United States. So I hope good health to everyone.
Okay.
You too.
Thank you very much.
My pleasure.
Thank you.
Bye-bye, Jeffrey. Have a good time. Bye-bye.
Thank you.
See you all soon.
Okay, thank you. Okay, was good, né?
Foi muito bom.
É que eu prometi para ele que ia terminar às 8. Nós passamos da... Ele tá com a família lá, por isso que não deu para... Mas acho que foi legal, né? Eu acho que
Foi legal.
deu para... Depois, Edgar, você explica para todo mundo a técnica, tá bom?
Só você que não entendeu, Marcelo.
De novo.
Tchau.
Você faz um esqueminha para a gente, vai, Edgar.
Ok.
Tá bom, pessoal. Tchau.
Tchau, pessoal. Boa noite.
Valeu. Boa noite. Tchau.